Back up on Chapter 7, Part 2, and we're going to start with the stages of labor. This is on page 216 in your book. So, there are 4 stages of labor. Stage 1 is 0 to 10 centimeters. Stage 1 has 3 phases. Phase 1 is our latent phase. That's when the patient is dilated from 0 to 3 centimeters. It's kind of can be a long phase. Our active phase, phase 2, is when she's dilated from 4 to 7 centimeters. Sometimes this can be fast, sometimes it can be slow. And then phase 3 is our transition. This is when she's dilated from 8 to complete, 8 to 10 centimeters. So complete is 10 centimeters. Usually this moves along pretty quickly. In your book it just explains these. Usually, if you want something for pain, it happens during the active phase, epidural, and some kind of analgesia. And then our transition is, like I said, pretty quickly. She starts feeling the pressure, maybe even her water breaks, has some bloody show. And then there's characteristics listed in your book as well on page 218. Yeah. But that's our phase, our stage 1. Okay, a lot of support, spirituality, different positions you can get in, and they do practice these at Archbald and at Colbert Regional. Pain management, like I said, usually happens there. Stage 2 is our second stage, and we'll go back to the pain stuff. Stage 2 is complete to the effacement and delivery of the baby. So from complete 10 centimeters to the time we have a baby. And stage 3 is from delivery of the baby to the delivery of placenta, usually 5 or so minutes. And then stage 4 is the first hour after delivery. Okay? Let's look on page 220. Go back. We're going to talk about some different positioning, and so we want to avoid our supine position, okay? Winking lollipop. Remember me talking about the vena cava being on the right side of the body? So we don't want to decrease our blood pressure or uteroplacental insufficiency because she's laying supine or on the right side. But supine is usually avoided because it does cause that pressure on the vena cavas. We usually kind of tilt her to the left side or sit her in like a semi-Fowler's, but no supine, no right side unless it's positional with the cord or the baby's heart rate. Okay. Pain management. So there are non-pharmacologic measures such as relaxation, music therapy, massage, touch, focus strategies. And so all of this is listed in your book. You can read through that. Some people have a doula come in as part of their birthing plan, and this is just like a labor coach that provides comfort and different types of non-pharmaceutical measures. Okay. There is something called hydrotherapy, and this is the use of warm water to promote healing. Let's see. It's on page 221 here, the water therapy. If the woman is experiencing back labor, okay, this is a winking lollipop again, back labor, this usually means that the fetal position is what we call OP, which is occiput posterior. This means the fetus spine is directly parallel to the mother's spine. So it's back to back, and that can cause a lot of back pain, back labor. She's usually assisted to a side lying position or even knee chest position. I'm sorry, hands knees position. It says in a tub. Well, the hospitals don't have tubs that we can get in around South Georgia, so we just get her on the bed and put her in the hands and knees position. Okay. There is hypnotherapy and yoga, ice and heat and cold, and then of course other relaxation techniques. So there's different types of blocks that we can do with spinal blocks, epidural blocks, pudendal blocks. These are blocking those nerve receptors to the uterus. So if you go in through here, it goes around and blocks the areas where those nerve receptors are. Okay. There's a difference between analgesia and anesthesia. Okay, you need to know the difference. So analgesia is a relief from pain, usually with some type of pain medicine. Anesthesia is the block of the sensation. Okay, so just know that there is a difference in those words. There's some boxes on page 224 that I want you to be familiar with. Let's go back over here to this. This is just talking about the different stages and phases again. So you have everything that you need to know about those, the transition. And then the expulsion of the fetus, placenta. Stabilization is our stage 4. Remember, that's the hour after delivery. And then we have how they're faced in each one. Okay. All right. So let's go back over here. In the first stage of labor, she may want some pain medicine. Usually second stage, but sometimes first. Remember, that's 0 to 3 centimeters. Okay. Vaginal birth, they can have the epidural or spinal. If it's a vaginal, we think it's going to be a vaginal, it turns into a C-section, they can make that epidural a spinal block. Okay. But usually if it's a scheduled C-section, it's usually the spinal. Sometimes they do epidurals, but usually it's the spinal. Let's see. On page 224, 225 at the top, you have some types of the opioids that are used: Dilaudid, Demerol, fentanyl, Zafenta. Stadol is another one that they use, and they usually use the Phenergan with these medicines because they work better together. Okay, Stadol, Phenergan, fentanyl, Phenergan, Dilaudid, Phenergan, Demerol, Phenergan, and what do all of these opioids do? They can cause nausea, vomiting, right? So if we give the Phenergan with it, it also helps the medicine to work better, and it takes away that nausea. Excuse me. Okay. Page 226 is just more about the blocks. The pudendal block, let's look at this one. This is when they're just blocked in that perineal area. Okay, the perineal area is blocked, like if they have a tear that needs to be repaired or a episiotomy that needs to be repaired and they didn't get an epidural. Anesthesia providers can come in and do the blockage just in that pudendal area. So spinal anesthesia blocks happen in that T area, right, at the spine. We do have something called, and it's not really in here that much, but I will show you a video in class of a spinal headache. Okay, it's a big thing. We may talk about it a little bit later too in chapter 8, but we will watch a video in class. Okay, but the spinal headache can happen when a spinal or epidural is done, the anesthesia provider goes too far, goes through the epidural space, and they can start leaking out the cerebral spinal fluid. So, of course, we know that the spinal fluid cushions our brain, right? So if there's a leak happening from a puncture, from a blockage that was assisted or was supposed to help with pain, that spinal fluid is leaking, then the patient's going to get what we call a spinal headache, okay? The only way it is relieved without anything done is time, which it can take weeks, or her laying completely supine. So remember, this is after the birth, right? So it's okay for her to lay supine now. But when she sits up, she has an excruciating headache. If you've ever had one, you know exactly what I'm talking about. So we can go in and we can do like IV caffeine. We can do what I ideally think is the best option is the blood patch. And so we'll watch a video on that. But it's just where you draw blood out of your arm, and in a sterile manner, you hand it to the anesthesia provider, and this is like about 10 to 20 milliliters of blood. So it's not, it's sometimes up to 30 and 40, according to how much they want. But then that blood is injected into the same spot where the epidural was given, and that blood clots and patches that hole. They lay them flat down for a couple of hours, and when they sit up, hopefully it's patched over that hole to stop the CSF leakage. So we'll talk more about that in the video. Alright, so this is where we go in the T area and then the L area as well. It's according to who's doing it. Usually it's that like L1, 2, 3. Epidural can be even lower. Alright. Usually I've always seen them, I think I have one provider that has done it laterally, but they usually do a sitting position leaning forward. So I want you to look on page 226. Let's go back up here, where it's talking about the complications. So a complication from a lumbar epidural, of course, can be the headache, but there's another one I want you to know, and this is hypotension. So as a labor and delivery nurse, I would assist with epidurals very often, and when the provider would come up, you know, we had to pull medicines, we had to get fluids, monitor blood pressure every 1 minute while the epidural is being done. And it was very, very important to bolus the fluid, okay? Bolus the IV fluid, because these epidural blocks have a major complication of hypotension, okay? So if you bolus enough fluid, then you're not going to have that problem, because you're filling back up the veins from the vasodilation of the medications that they're using, okay? They use some bupivacaine, they use fentanyl, it's just according to the provider. But a major complication, and I've seen it happen a million times, is hypotension. Not with my patients, because my patients got about 3 liters of fluid. So 3 bags of fluid in the process of about 30 minutes. I would get a pressure bag and bolus it in, and they would not be hypotensive. So I had a lot of questions from my coworkers, you know, why do you give so much fluid? Why do you give so much fluid? I'm like, well, how many times has your patient getting an epidural had hypotension? You know, they pass out, they start vomiting just from the hypotensive crisis, and they're like, several times I said, well, mine has never happened because I bolus them. As soon as I lay them back, give them about 20 minutes or so, I place a Foley catheter. So with that urethral catheter, whatever fluid they don't need, is coming out, right? So unless you've got somebody with CHF or anything like that, then of course I'm going to be more cautious. But You can avoid this hypotension in someone getting an epidural by just simply giving them enough fluid, okay? On page 230, it talks more about this, so let's go there, and you can read all about that, okay? Let's see. Let me find it, sorry. So see, T10 to S5 is actually where the blocks are, okay? Right here it's talking about the maternal hypotension. So just make sure you read through this, okay? Make sure you read and understand that cardiac or that hypotensive episode that can happen, okay? So let's talk about some complications with the spinal epidural block, okay? So of course the mom can refuse, right? Local or systemic infections, coagulation disorders. So what are we going to check when we're giving a report to the anesthesiologist that's coming to the floor to do the block? So we're going to give platelet count, okay? So because we need to know, is she clotting like she should, right? So if her platelets are 100, do you think they're going to get it? No. So we don't want a low platelet count. So that's one of the things that anesthesia usually looks for. I give it to them when I call them. I give them, like she's gravida 2, para 1, she's 5 centimeters, patient of Dr. So-and-so's, blood pressure, no complications with this pregnancy, blood pressures, whatever. If it's normal, I say it's normal, and then, platelet count of whatever, hopefully 200. So, but make sure that you always are reporting that, okay? Alright. 233 is talking about some other things that happen. So, in our second stage of labor, remember this is where we're pushing, right? Remember, let's going back up here, and I'll just leave this kind of pulled up until we finish this. This is completion to delivery of the baby. So we want her to push effectively, okay? When I'm pushing a patient, I do what's called ironing the perineum. So you kind of get your 2 fingers, your index finger and your middle finger, and pull down on this tissue on both sides, okay? This is called ironing the perineum. This decreases the incidence of laceration, of tears, or a need for an episiotomy. You stretching that tissue, and just like everything else on a woman's body, hopefully it bounces back. Not saying it's going to be exactly, because if you've ever had a baby, that your body's never the same afterwards, right? But it decreases the fact that you would have to get sutured or repaired. So if you'll just iron that perineum, pull down on that tissue, okay? So this is just the different types of lacerations. There's 1st degree through 4th degree. So first degree is what I've always called like skid marks. Just a little tear coming out of the perineal skin. 2nd degree is involving several layers. The skin, mucous membrane, and the vaginal fascia. And then the 3rd is more tissue. Like it's all the way from the bottom of the vaginal opening all the way to the rectal sphincter. And a 4th degree extends all the way through the rectal mucosa. So it's from the vaginal opening all the way to the rectal opening and through the rectal opening. It's very painful from first-hand experience. Took about an hour and a half to sew me up from my first pregnancy, so it's not fun. Thank God there was no complications afterwards. So, all right. So moving on. This tissue right here, this first degree is just a little bit, second degree is about halfway, third degree is all the way to here, and fourth degree is all the way from the vaginal opening through the rectal opening. Okay. And this descent, this is the internal descent, flexion, internal rotation, and extension. So our fetus turns when they're coming out. When they're getting into the pelvis area, they'll turn to come out of the vaginal wall. Okay. Then, of course, we clamp the umbilical cord at delivery, and let's look at the different types of the different sides of the placenta. So, placenta, this is delivery, of course, vaginal delivery. We have, I'm trying to find these pictures. So, and you'll see the terms up here. Let me get back up here. So, we have what's called the shiny Schultz, the Schultz mechanism, and then we have one called the dirty Duncan. Okay, so the shiny Schultz and the dirty Duncan. You need to know those terms because I will be asking you in clinical. Okay, so please know these terms. So this is the shiny Schultz. It's the shinier side. It's the fetal side. Okay, so this is the umbilical cord. This part is where the amniotic fluid is, and this other side is called the dirty Duncan. It's the maternal side. Okay, this is the part that's attached to the uterine wall. Okay, so you have all of these parts that are attached to the uterine wall. So when we have a delivery, we will check these kind of lead-ons is what they are, and we check those to make sure they're all intact, because we don't want part of a placenta to stay inside our mom, because that can cause a hemorrhage, a vaginal postpartum hemorrhage, because our body's mechanism is to try to get rid of it, and so she's going to bleed more, and we do not want to do that. So at delivery, during that fourth stage of labor, or the third stage of labor, sorry, we're going to be pushing Pitocin, okay? And that's to get our uterus to clamp down and our placenta to let go and be delivered, okay? And this is it right here. This is one of your drug templates, so you should know all about that, okay? But that's our Pitocin. It is oxytocin. It's a natural, this is a synthetic form, of course, but we produce this oxytocin when we breastfeed as mamas. So, induces the milk letdown, reduces postpartum bleeding, and induces labor. So, remember me talking about the contraction stress test and the nipple stimulation? This is what we're using that for, okay? We're trying to get that natural oxytocin to be produced to have contractions, okay? And this is the examination. So this is the actual, the entire sac, amniotic sac that they're holding up now. And if we get a chance to see a delivery in clinical, I'll show you this, and hopefully we can talk about it, okay? There's a case study in your book. Always, always, always do these case studies, okay? This is on page 239. Make sure that you understand, because we may talk about this in class some. All right, and this is it for chapter 7.